Well, welcome to this lecture entitled Childhood Obesity Programs, Comparative Effectiveness of Interventions. My name is Professor Brian Mancom, and I'm an assistant professor in the School of Public Health and Primary Care at Fiji National University, and I'm also a professor in the Public Health Training Program at the College of Micronesia, FSM, in Pohnpei. So some of you have heard from me before, others of you, this might be the first time you're hearing from me, but just a little bit about myself. Like I said, I'm an assistant professor of Epi and Biostats, and I'm also the coordinator for disaster risk management at Fiji National University. And then I'm actually spending the next 3 years here with the College of Micronesia, FSM, in Pohnpei, working with their public health training program in a variety of different capacities, and also providing these continuous professional development lectures across the Pacific. And there's just a little bit more about me. If you have any desire to know about it, please feel free to read through that. Otherwise, I'm just going to go ahead and skip ahead and start into the lecture. So what is it we're going to talk about today? Well, we're talking about the prevention of childhood obesity, and we're talking about different settings approaches to that. All right. So we'll start out by introducing childhood obesity and the various programs that are designed to prevent it. We'll talk about some of the objectives of the systematic review that we're going to be talking about today. It's basically a meta-analysis of a wide range of different programs that were undertaken in different settings in the United States, okay, to look at whether or not it was most appropriate to approach childhood obesity in school-based programs, home-based programs, community-based programs, or a combination of those, all right, and also whether or not it was appropriate to look at obesity prevention in clinical-based settings, and in particular primary care-based settings. So that's what we're going to talk about today, all right. So what we'll do is we'll just do a little bit of background information, and then we'll go through and talk about the different settings, which were most effective, which were least effective, and what you're going to find, here's a little spoiler alert for you, what you're going to find is that when we combine different settings, in particular school and home and community, is when we found some of the more effective interventions for childhood obesity prevention. All right, so as you know, as a public health or a medical or a nursing or a variety of different allied health practitioners across the Pacific, child obesity and child overweight are very high prevalent problems in the United States as well as out here in the Pacific, all right. On the mainland in the United States as well as Hawaii and Alaska, it affects about 1/3 of children and adolescents. So like I said, it's a significant problem in terms of being a catalyst for a wide range of non-communicable diseases such as type 2 diabetes, obesity, a variety of different cancers, cardiovascular disease, stroke, and so on and so forth. And it's a relatively recent problem. As you can see there, since 1980, the rates of obesity have tripled for children in the age range of 2 to 19, and the risk of obesity is higher among minority and low-income populations. And so when we look out here in the USAPI, the United States affiliated Pacific Islands, we see very high rates of obesity and associated non-communicable diseases. The Pacific is actually the most obese region in the world, and along with that, we have very high rates of type 2 diabetes, for example. So if you were to look at data from 2012 from the International Diabetes Association, what you would find is that the top 4 countries in the world for prevalence of type 2 diabetes type 2 diabetes, are found in areas like the Federated States of Micronesia, Palau, the Marshall Islands, and Kiribati. If you were to look at just straight obesity statistics, what you would find out is that areas like Tonga have the highest rates of obesity in the world. So it's a significant problem out here in the Pacific. And in terms of the prevention of childhood obesity, really, if we're able to take a child, okay, and we're able to guide them so that they develop healthy eating habits, healthy lifestyle habits, and we prevent obesity from developing in childhood and in adolescence, then statistically, that child is going to is going to have a better chance of remaining at a healthy weight throughout their adult life. Whereas if we take a child and very early on that child develops obesity and overweight in their younger years and into their adolescent years, then we know that statistically speaking, that individual is also going to be an overweight or an obese adult as well. So it's very important in terms of this idea of how do we prevent childhood obesity. So I've mentioned quite a bit of this already, but there's a wide range of health consequences associated with childhood obesity. And like I said, or like I alluded to, overweight children and adolescents are actually at greater risk for health problems when we compare them to their normal weight peers. And like I mentioned before, they're also more likely to become obese adults as well. And just like adult populations, if we take an obese child or an obese adolescent, they're more likely to suffer from type 2 diabetes, hypertension, hypercholesterolemia, and so on and so forth, and a variety of different things that you see there. And in particular, there's a lot of cancers are now associated with obesity. For males, prostate cancer has a direct association with diets that are high in fats and red meats. For females, breast cancer seems to be the one that's most closely associated with obesity. So obviously, if we take a child and they develop obesity early in life, then they're more likely to develop some of these cancers a little bit earlier in life as well. And that's a particular problem here in the Pacific where we just don't have the resources to address things like prostate cancer, breast cancer, and so on and so forth. And so even though we have an increasing burden of those, we don't have the manpower to address it. And so what we do is we have to put economic resources towards sending these individuals overseas on medical referral for treatment. So we spend large amounts of money sending them to places like Hawaii, India, the Philippines, and so on and so forth. Now, there are also psychosocial consequences associated with obesity. So we know that overweight children, obese children, are more likely to have eating disorders such as bulimia. We also know that there's going to be mental health issues, that they have higher rates of depression, they have lower self-esteem. We also know that obese children are more likely to engage in substance abuse as well. Now, there are a wide range of factors that can contribute to childhood obesity. Genetics does play a role, so if we've got a child that comes from a family that has a genetic predisposition to obesity, then that's going to be a problem as well. But just like a lot of other issues that we deal with in public health, where there tend to be a genetic component, there's also a lifestyle component as well. So just as in we could take an individual that has the alcohol gene, but that individual chooses not to drink alcohol, then the alcohol gene's not going to become active in terms of producing an alcoholic. It's the same concept here. If you take a child that comes from a home that has a genetic predisposition to obesity, but that child learns healthy eating habits and is supported in the psychosocial environment of the home and the school environment, then, and develops healthy eating habits, healthy lifestyle habits, they're less likely to develop obesity as well. So you got to remember what we're dealing with here in terms of obesity, at least at the level of the individual, is really a biopsychosocial model. There's going to be biological factors, psychological factors, and social factors that are going to influence whether or not a child develops into an obese or an overweight child. Now, of course, there are environmental influences as well, such as the local community, the social customs. Does the community have access to physical activities? Does the community have access to resources to help the child maintain a healthy weight? And there's also these policies that are implemented at the regional, the national, and really the broader economic level across regions such as the Pacific that impact whether or not a child comes into a home that has the ability to feed him fresh fruits and vegetables, or is the home economically disenfranchised and they don't necessarily have access to fresh fruits and vegetables, but they have to rely on things like turkey tail and spam and rice. In terms of these large-scale economic and nutritional factors, I do have a lecture entitled Global Economic and Nutritional Shifting, the Roots of the Global NCD Pandemic, that go much more in depth into that. And so I would encourage you to go out and find that on my YouTube page as well. So preventing childhood obesity is the approach that we want to take. And that's the approach we want to take because once we have a child that is obese, it becomes very, very difficult to treat that child and to get that child back down to a normal weight, particularly if they happen to come from an economically disenfranchised home, or if they come from a home where other siblings or mom and dad or other caregivers in the home happen to be obese as well. So what that means is that prevention becomes the key to the fight of this growing obesity epidemic, because once again, if we can take a child and we can prevent them from becoming overweight or obese, then we can prevent a whole generation of adults from becoming obese and overweight, and that reduces the NCD pandemic that we're fighting, because once again, that primary causative factor of obesity isn't present in these communities. And really what's happened is we've kind of seen an approach among agencies like the World Health Organization as well as the Institute of Medicine in the United States, and they've said what we need is a comprehensive approach to fighting obesity, and in particular we need a comprehensive approach that focuses on children. All right, so in other words, the main goal of these approaches becomes to prevent children who are not overweight from becoming overweight or obese. Okay, now this isn't saying that we simply ignore the population of children and adolescents who are overweight and obese already, but really what we're saying here is let's put a primary focus on preventing the development of another generation of obese adults. Okay. Now, what happens is that a lot of times when we place the emphasis on preventing the current generation of children from becoming obese, is that has a spillover effect. So in other words, if we increase physical activity programs in the home and we increase physical activity opportunities in the community, then what happens is that those kids who are already overweight and obese, they benefit from those programs as well. All right. Now, they don't benefit statistically, they're not going to benefit to the extent of the kids who are being prevented from becoming obese and overweight, but there is spillover effect into those children. But unfortunately, what we're really saying here is the biggest bang for our buck is taking kids who are right now at a normal weight and keeping them at a normal weight. Okay, so let's kind of get into the meat and the bones of the presentation here. So, because like I said, what we have here essentially is a comparative effectiveness review. And I want to mention that I didn't do this, okay? This is based upon work that was done uh, on behalf of the U.S. Department of Health and Human Resources, okay? And so what they did was they went out and they did a meta-analysis of a large number of studies that looked at different settings of interventions, okay? And what they did is they wanted to compare the effectiveness of obesity prevention programs for children and adolescents. And the interventions they looked at dealt with diet, physical activity, or any combination of these, and they looked at them in specific settings, okay? So they looked at them in school-based settings, home-based settings, primary care clinic-based settings, child care-based settings, community-based settings. So community-based settings would be like, after-school sports clubs or community organizations, religious organizations, and things like that, okay? And then they also looked at a combination of the above. So they might look at an approach that's primarily in the school but has a home component. So they might have looked at a program at school that's designed to reduce the amount of soda that's being consumed by students while also increasing healthy options for school lunches, and at the same time might also look at homework being assigned to students in terms of educating their family about better eating patterns and so on and so forth. Okay, so like I said, they looked at them individually: school, home, primary care, child care, community setting, and then they looked at a combination of these. And they also assessed consumer health informatics interventions. And when I say consumer health informatics interventions, I'm talking about, uh, maybe a video presentation for the kids at school, or a computer-based training program in which children increase their health literacy by logging onto a specific website. Okay, so that was something else that they also looked at. So with the school-based interventions, okay, like I said, they primarily looked at things like change in the quantity and the nutritional quality of school lunches. Okay, they looked at increased physical activity at school, promotion of walk to school days, and so on and so forth. Okay, they also looked at some of the community-involved settings, such as improved community park access, performing community service, and so on and so forth. Okay, so while a lot of these deal with development infrastructures that are not necessarily present here in the Pacific, I want to point out that they are still applicable to the Pacific. Just because we're not in communities that are overrun with parks and walking paths and things like that doesn't mean that it isn't applicable to look at what is available in a community to encourage physical activity. Okay, so for example, here in Pohnpei, when I drive around, I notice that wherever there's an empty lot on the side of the road, there's kids out there playing. You know, they've taken an old empty basket and they've tacked it up to a tree and they've got a basketball court or something like that. Okay, so we shouldn't say to ourselves, well, these are not applicable here simply because they were tested in areas like the United States. They are applicable here. We just need to be creative in how it's applied. So the home-based interventions, they looked at things like altering the food purchases of the home, whether the family was involved in physical fitness, health education to the mother and the father and the caregivers in the home to help them understand the need for a healthy diet, and so on and so forth. Okay, and then they looked at primary care-based interventions. Okay, this would be with your family doctor, your pediatrician, nurse practitioner, or in outlying areas, this might be a nursing post or a health assistant post. Okay. And what they looked at was, once again, it's some type of health education to caregivers in terms of changes that they could make at home, such as increasing the daily servings of fruits and vegetables, limiting screen time, promoting physical activity. And in particular, one thing that they looked at was this idea of altering the perceptions of not just counting meals in a day, but teaching people how to count caloric intake. Then they looked at childcare-based settings. They looked at things like offering fruits and vegetables throughout the day, how to increase physical activity, limiting milk and juice, and increasing the amount of water that's served. Okay. Then they looked at community-based settings and environmental level interventions. So this would be like a policy, systems, and environment approach to change the built environment, give people greater access to community markets where locally produced fruits and vegetables are being sold and things like that, increased access to areas where kids can be physically active in a safe environment. Okay. And then, like I said, they also looked at this idea of consumer health informatics based interventions. And this involved things like web-based promotions that I mentioned, video-based promotions, and the ability to deliver health literacy messages other than face-to-face to children in either the community or the physician's office or at school, and so on and so forth. So those were our settings of the interventions. So what specifically were the questions that were asked about the different settings? Well, specifically, they wanted to know the comparative effectiveness of the following interventions, and they were particularly looking at for the prevention of obesity or overweight in children. Okay, so once again, they looked at school-based, they looked at home-based, they looked at primary care-based, child care-based, community or environmental level-based, the health informatics, and then probably the most important one that we'll talk about here in a minute is they looked at multi-setting based interventions, so combining school with home, teaching the kid, increasing physical activity at school while also teaching increased health literacy, but then giving the kids homework. Go home and run around the yard 5 times. That's your PE homework, something along those lines. And what you're going to see is that the multi-setting interventions tended to be the more effective ones. But we'll get into that in just a minute here. So what they did then is they rated the strength of the evidence. So once again, what they did is they went out and they basically they searched things like PubMed, all right, and they came up with something on the order of 130 different interventions that had been undertaken in the past 20 years or so, and then they ranked them. Was this a school-based intervention? Was this a home-based intervention? Or was this a combination of different approaches? And then what they did is they rated the strength of the evidence, and they rated it as either having high high evidence. Okay, so in other words, further research was unlikely to change the confidence in the estimate of the effect of the intervention. They could rate it as moderate, which meant that further research could change the confidence in the estimate of the effect and may change actually the effect itself. And then they could rank it as poor, meaning that further research is likely to change the confidence in the estimate. And then they could also rank it as sufficient, simply meaning that sufficient evidence wasn't available, okay, to permit some type of a conclusion at this time. And the insufficient, we'll see that there were a number of them that were ranked as insufficient. And when it was ranked as insufficient, what I want you to keep in mind is that doesn't mean that it wasn't effective. It simply means that based upon the meta-analysis of the 130 different interventions, that there simply wasn't enough evidence within those 130 different interventions to make a decision whether or not this was an effective way to approach preventing childhood obesity. And we've got a couple of examples of that I'll give to you in just a minute here. So let's start out with the school-based interventions, and we'll just work our way through here. So the first one is they looked at school-based interventions only, and in particular what they looked at was diet interventions or physical activity interventions. All right, so they didn't look at a combination of them. So in other words, they looked at could they reduce consumption of sodas at school? Okay, or could they increase physical activity? Or could they provide healthier food options for kids in settings where a school canteen or a school cafeteria was available? And what they found was when they looked at interventions that dealt only with diet or only with physical activity, it had a very moderate effect, all right? But it still had an effect. All right. Then they looked at school-based interventions only where they combined diet and physical activity. Okay. And what they found was they had insufficient evidence. Okay. So in other words, they may not have had enough studies in their meta-analysis that combined both diet and physical activity. Okay. So once again, that doesn't mean that based upon insufficient evidence, we should rule out developing diet and physical-based activity interventions within our schools and the communities that we serve. Only that if we do that, we would want to make sure that we have a good program in place where we could evaluate the efficacy of our intervention to see whether or not it made the changes we had hoped it would make. And evaluation is a very difficult thing to do in terms of public health programs. So if you're going to go out and you're going to design a new program, it's important that you have an evaluation program in place so you can determine whether or not your program met its desired effect. Then, as you can see, our third one down, they looked at school-based interventions that had a home component. So in other words, they combined physical activity in school with a home-based component. So in other words, this would be like I mentioned before. The kids actually had PE homework, whether that was to go home and run around the yard or go to the park or play with the dog or play with your sibling or take grandma for a walk or something like that, or whether it was go home and do a little presentation for your family on making sure you get 5 servings of fruits and vegetables a day. It was some combination of school and home-based component that involved physical activity and a home-based component. And as you can see there was very high evidence that suggested when we combined home with school, all of a sudden we had high ability to prevent obesity and overweight in children and adolescents. Okay, so we're already seeing that. Okay, like I said, what you're going to see is that when there's sufficient evidence, that combining of different settings tends to be a very positive impact. Then we looked at school-based interventions with a home component in which we were combining diet and physical activity in school with a home-based component. All right, and what we found is that we had a moderate effect. So in other words, we still had an effect, but it was a moderate effect. Okay, so continuing our school-based interventions here. So next what they did is they looked at school-based interventions with a community component. Okay, so this might be after-school sports clubs that are sponsored by the school or by a community partner, such as a YMCA or a church or something along those lines. And what they found was that when we combined school-based interventions with a community component, that it had a moderate effect. All right, and moderate is positive. Any effect is positive in terms of the prevention of obesity. But look at the second one here. All right, here's the take-home message. If you remember nothing else, difference, okay? I want you to notice that the school-based interventions with home and community had a very high effect, all right? And remember, the high effect suggests that we have sufficient amount of evidence to say that this is the gold standard in evidence-based public health practice for the prevention of obesity at the community level in children, okay? And that's really the entire purpose that we're giving you this presentation today, is that you're out there, you're the decision makers, you're the policy makers in your public health agencies, or you're the program staff in your public health agencies, and you're the ones that are tasked with designing interventions, all right? You already know that the prevention of obesity in children and adolescents is critical to the survival of that next generation, all right, and in lowering the prevalence and the incidence of type 2 diabetes and cancer and cardiovascular disease, okay? So we're giving this to you so that you can use evidence-based approaches to designing these interventions. You have the ability to say to your managers and your policymakers and your political heads that oversee your organizations, aha, we have this meta-analysis, we have this evidence, and we know that school-based interventions with home and community components, those are the ones that have very high efficacy in terms of the prevention of obesity and, later on diabetes and cardiovascular disease in children that then go on to be adults, okay? Because really, if you think about it, how many of you in either your clinical roles or your public health roles or your whatever role you happen to play, how many of you have all the money and all the program staff that you need? None of you do. We work in a very resource-limited environment in public health in which we're increasingly asked to do more, but we don't necessarily always get the monetary and the human resources that we need to go with it. So we want to make sure that there's the greatest bang for our buck. That's evidence-based public health right there, and that's what we're giving you here right now. We're giving you a meta-analysis that shows you evidence-based public health says if you want to decrease obesity among children and adolescents, this is the way to do it, okay? Sorry, I got off track there. But let's look at the third one, school-based interventions with a consumer health informatics component. So remember, this would be like combining physical activity and diet in school with a health informatics component such as audio, video presentation, online teaching of health literacy, and so on and so forth. And what they found is, once again, insufficient evidence to support that. All right. Now, once again, we're not saying that that's not an okay or a good way to approach it. We're simply saying that based on this meta-analysis, there wasn't sufficient evidence to say that school with consumer health informatics led to a real great reduction in obesity, which is probably okay, especially here in the Pacific-based settings where we don't always have access to these online teaching tools and so on and so forth. All right, so let's look at home-based and childcare-based intervention. So we'll start with home-based interventions, and you can see right off the bat there was very low evidence, all right? So in other words, programs that only targeted the home, such as family education on healthy portions, portion control, counting calories versus the amount of consumed food consumed, behavioral modification of parents and other caregivers, really showed no benefit. All right, and probably, based upon this meta-analysis and the structure of evidence, additional studies aren't going to change our mind on that. Now, does that mean you shouldn't involve home-based interventions? No, it simply means that there's a recognition here that there needs to be other elements involved, such as the school and the community. Same thing with childcare-based interventions, so like reducing juice and whole milk consumption, increasing physical activity, simply no evidence to show that that in and of itself, all by itself, was an effective way to decrease childhood obesity and overweight. All right, so let's look at community-based interventions with the school component, okay? So here we looked at diet and physical activity interventions that are based in the community, but with some type of a school component, all right, such as teaching increased literacy in the school day, but then having peer support after school sports clubs and so on and so forth. And once again, it had a moderate effect, but it still had a moderate effect. It still had some type of intervention that decreased the rates of obesity and childhood overweight in both children and adolescents. Okay, so once again, we're continuing with that take-home message that suggests that when we start combining elements together, that's when we get the greatest impact in terms of the prevention of obesity in children. And finally, primary care-based interventions, okay? Only in the primary care, all right? So this is physicians and nurse practitioners and dietitians and health assistants taking the opportunity when they have children and parents present to educate them, to increase their health literacy on appropriate decisions in terms of lifestyle interventions that the family and the children can be taking. And what they found was that there was insufficient evidence to support primary care only based interventions. Does this mean that those of you who are nurses and physicians and dietitians, so on and so forth, that you shouldn't educate your patients when you have that opportunity in the primary care setting? No, it doesn't mean that. It simply means that right now, once again, there's insufficient evidence. Once again, that could mean that there weren't enough studies included in the meta-analysis to support it, okay? But what it does is, once again, it reinforces that idea that if we're taking the opportunity in multiple different settings to educate the public, increase physical activity, increase access to fresh fruits and vegetables among children, that the more opportunities we have to educate in different settings, the better results that we're going to get, all right? But simply educating in the primary care-based setting, yeah, isn't really sufficient evidence to support that right now. So what are the conclusions? What are the take-home messages in terms of evidence-based, gold standard public health practice in terms of preventing obesity and overweight in children and adolescents? Well, school-based programs involving dietary or physical activity interventions are effective. We have moderate evidence, okay? When we combine a home and a community component with a school-based program, that also works. In fact, we have moderate to high efficacy in terms of that, okay? So what does this mean for you, the public health practitioner out there in the Pacific, whether it's in Vanuatu or Saipan or Kiribati or Palau or the Marshall Islands, wherever it happens to be? What it means for you is that you've got to look at your own community, and you've got to look at the level of community involvement, and in particular, you need to look at when you got to look at identifying different types of communities, okay? When I say community, I don't just mean everybody living in a specific area of Pohnpei, all right, or Saipan. What I'm talking about is, I mean, it can be the people living in that specific community, but what I'm talking about more particularly here is what we call heterogeneousness, the social heterogeneousness of the population. Do we know where a specific ethnic group lives? Do we know where people who attend a specific religion live? Do we know where people who are part of specific cultural communities live? Because those are the communities that we want to partner with, because they're going to be very heterogeneous. And once we get involved with those populations, then we're going to figure out, is it better that we do home and school, or is it better we do community in school, or what type of involvement can we get from the health centers that are in those communities, okay? So in other words, there really isn't going to be any single one right formula. It's going to depend upon you analyzing the specific communities in which there is a high risk of obesity and overweight in these children. Okay. Once you've done that, you can determine whether or not it's the school, the church, the home, the school, the sports club, the home. All right. But the take-home message is, once you've identified those communities, it's going to be a combination of factors, probably involving at least the school and at least the community. All right. So find the combination of factors that are going to work for your population. Now, just two more quick slides here, okay? What are the public health messages that we as public health educators and public health planners and clinicians and so on and so forth, what are the public health messages that we need to be sharing with the communities? All right, in which we know there's a risk of childhood obesity, all right? What are the things that we want the community, the parents, the caregivers, the teachers, the children themselves, what is it that we want them to know? Well, we want them to know that we're concerned. We know childhood obesity is a problem. We know it's a risk, and we want the parents and the patients and the community to know that we're aware of it and we care, okay? We want the general public to understand BMI. All right, even though BMI is probably not the best calculation, it's the calculation we have. It's cheap, it's easy, it's readily available, okay? And we want the people to understand what BMI is, why we use BMI, and we also want them to understand that BMI has been adjusted for the fact that here in the islands we tend to have larger bone structure. All right, that type of adjustment has been taken in because one of the common things I hear is that, well, BMI is not appropriate for islanders. Well, it's been adjusted in terms of its use here in the islands, okay? We want the public to understand that there are factors that contribute to overweight and obesity, and that includes children not being physically active, kids sitting around watching television. All right, and don't tell me it's not out there because in the communities I work in Fiji, I go into these tiny villages where people live in very traditional homes that are still with thatch roofs, and they've got a flat screen TV. They've got a DVD player. All right, they're loading up the USB thumb drive into the back of the flat screen TV with the movies that they've downloaded from the internet on their smartphone. All right, so screen time is a problem here in the Pacific. We want them to understand that there are empty calories in our diets, and in particular, there are empty liquid calories in our diets. We see a lot of kids walking to school and they've got an orange soda. All right, and a loaf of white bread. And what do we say? We go to the parents, we go to the community, and they assumed that, well, it's orange, it's fruit, it must be healthy. Well, no, we need to educate them that those are essentially empty calories. We want to educate on what's an appropriate serving size. All right. I think that here in the Pacific, because we are so culturally inclined to like celebrations and festivals and holidays, and we tend to center those things around the consumption of food. And don't get me wrong, I love it too. I love going to the big parties. I love going to the, what do they call them here in Pohnpei? The one-way table, where you've got this huge table and they give you like a basin, and you only get to go through once, but man, you can fill up that basin. All right. We need to educate on what is an appropriate serving size. Okay. We need to educate on how do we monitor daily total caloric intake as opposed to daily total food intake. So in other words, you'll have people that say, well, I only ate 3 meals today. Well, you ate 1,500 calories in each meal. All right. So what are you up to? Like 4,500 calories in a single day. Okay. And we want to educate them on important things that can be done at home to keep children at a healthy weight. One of the things, and I know that we try to stay away from threat messages, in public health because they don't always work, but we can tailor emotional appeals. And one of the emotional appeals I've seen that has actually worked in the past is to take a healthy little child and to show what that child becomes. All right, in terms of the obese male that's suffering from type 2 diabetes and sitting in the intensive care unit waiting to have their legs amputated. All right, because the diabetes is out of control. So we want to educate people about how to keep children at a healthy weight and help them understand the very negative health consequences that occur later in life down the road for these children. All right, so we've talked about that already, the healthy consequences of overweight and obesity in children, okay? And for you in the public health sector, we want you to understand the effectiveness of the various interventions that we presented today, and that's something you can pass along to the populations you serve. We're not just making this up. We know these things work. We have an evidence base to support the interventions that we want to develop, okay? And we want to help people understand what resources are available in the community because I know, having worked in a large number of jurisdictions here in the Pacific, a lot of times there are resources available, but people don't know about them. So we want to give them access to and knowledge about them, okay? And we also want to talk to them about what can be done if healthy food or safe locations for physical activity are not easily accessible. So in other words, how do we help the communities become effective advocates for themselves? Once we tell them that you need to be physically active, and once we convince them to actually be physically active, which is a huge barrier in and of itself to get them to cross over from knowledge towards good attitudes and actual behavior, but once we get them to that point and they realize, oh, my community doesn't have walking paths, my community doesn't have basketball courts, and so on and so forth, we want them to have the ability to become actual advocates for themselves themselves with the policymakers and with the political key stakeholders that exist in our communities, our governors, our lieutenant governors, our congressmen, whatever they happen to be in your jurisdiction. All right. So there you have it. All right. Once again, the take home message, if nothing else, is to help you understand that an obese child is going to become a sick adult. All right. That's why it's so important that we focus on preventing obesity in children, and that this settings based approach in which we combine different settings, whether it's the school with the church and the school with the home and the church and the community and so on and so forth, that is the way to get the biggest bang for your buck. The more stakeholders, the more partners you can involve, the better. And as always, thank you so much for listening. Please go and check out my YouTube page. There's a wide variety of public health and other lectures there that might be of value to you. Thank you.